All right, friends, so let's talk about some infectious diseases. We're going to talk about the ears, nose, and throat. This is not a comprehensive set of infectious diseases that affect that region of the body. Some of the infectious diseases that affect the ears, nose, and throat are surgical problems, and we're right now talking about medical problems. So as far as abscesses go, etc., that's going to be a surgical topic. So ears, nose, and throat. Very common in practice to deal with this. If you've done a family practice rotation or if you're a family practice resident, you probably know that these are going to be most common in the fall and the spring, particularly in the months of September through November. Important to remember that these can be either bacterial or viral, and your physical exam skills are really going to come to play here. So not only is this important for your clinical practice, but it's also important for the USMLE because you need to know how physical exam findings are described. And in order to know how physical exam findings are described, you need to know what those physical exam findings are. So it's going to be paramount to the USMLE for these kinds of disorders because a lot of these are diagnosed clinically. So what we're going to talk about is acute sinusitis, acute otitis media, pharyngitis, which can be caused streptococcally, and influenza. So the offending organisms for acute sinusitis, and for acute otitis media, so acute sinusitis or a sinus infection or acute otitis media or an ear infection, 40% are caused by strep pneumonia, 30% are caused from Haemophilus influenza, 20% from Moraxella catarrhalis, and 10% from other or unknown. Pharyngitis, most of them are going to be viral, but the important ones, we need to detect these ones, are caused from group A beta hemolytic strep, known as Streptococcus pyogenes. And influenza is caused from the influenza viridae, or influenza viruses. All right, so before we talk about sinusitis, let's just do a quick review of what the sinuses are. The anatomy is not so important. I mean, I would know that you have maxillary sinuses down here and frontal sinuses here, but what you should know is that the sinuses are hollow areas in the skull that do get fluid in them, and they can get infected. They are lined with tissue, but they are generally hollow. And that's what allows our skull to be so light. When you're turning your head, it's supposed to be easy. If you had a dense 40-pound skull, it would be very difficult for us to turn our head, and that wouldn't be evolutionarily advantageous. So the sinuses give lightness and mobility to our skull. Now, it's also important to know that these are all continuous. So this is just a coronal view here, but if you were to take a three-dimensional view of these sinuses, you would see that everything's continuous. And they do drain. Here you've got your lacrimal duct, and it drains into the nasal passages. And so everything's continuous. It drains into the pharynx as well. And then here is a lateral view. Okay, so acute sinusitis is an inflammation of those sinus cavities, and what happens in acute sinusitis, what causes the symptoms is that when you get inflammation of the sinuses, it causes a blockage, and that blockage is problematic because you're secreting fluid into your sinuses, and as you secrete fluid, if there's a blockage, the pressure will increase, and that's what is known as sinus pressure. When people say sinus pressure, it's true. There is pressure in their sinuses, and that's because of inflammation and blockage. So the symptoms that most commonly present with acute sinusitis is facial pain. Well, look at this. Most of your sinuses are in your face. So when you get sinusitis, it makes sense that the pain's going to be in your face. A lot of patients will experience a headache, and that's because of the frontal sinuses are right above the eyes, so that can be perceived as a headache. Stuffy nose is also common just due to the congestion and inflammation. Nasal discharge can be present as well, and tooth pain, and that's because some of the maxillary sinuses are right up next to the molars. So that can cause perceived tooth pain. On physical examination, well, before we go to that, what I want you to know is that these sinuses since they're usually so light, and since during inflammation they get so much heavier, a lot of patients will tell you, or if you ask them, they'll tell you, that when they move their head up or down or to the side, that makes their pain worse. And the reason is just because of the pressure. So when you're moving something that's under pressure, of course it's going to hurt worse. So anytime you move an inflammatory object, it hurts. So if you have arthritis, it hurts to move your joints. If you have sinusitis, it hurts when your sinuses are moved. So these patients will have exacerbated facial pain or headache when they move their head. All right, so on physical exam, a lot of times you'll have tenderness on palpation, so you should be feeling their face, and on motion of their head, as I mentioned. The diagnosis for acute sinusitis is primarily clinical. You can do transillumination, which will be decreased. The theory behind that is that you should have air in your sinuses, and when you have fluid in your sinuses, or too much fluid in your sinuses, then the illumination will be decreased. I have never seen a physician do transillumination in my entire life, nor have I ever done it. So I don't really know why the USMLE continues to use this, but they do. So know that decreased transillumination is associated with sinusitis. The best initial test for diagnosis is a frontal skull x-ray. Again, you do not need to do this to make the diagnosis of acute sinusitis, but it is the best initial test if you're going to do an initial test. You don't have to do a test in reality. As a matter of fact, USMLE will often give you a patient with acute sinusitis, and they'll say, what's the most appropriate therapy for this patient? So if you have to do an initial test, the best one to do is imaging. And usually we do a frontal skull x-ray. You can also do CT. You can also do MRI. CT and MRI are obviously going to be going to give you more detail. But the frontal skull x-ray does a good job of visualizing the sinuses, and you should see an air fluid level if the patient has sinusitis. The most accurate test is a sinus aspiration. That's usually done in patients who have sinusitis that is refractory to therapy. So that should never be something that you do in a patient with acute sinusitis who's just having it for the first time. But that is the most accurate test. The treatment is going to be based on severity. So if you're dealing with adults, if most patients when they come in, they want you to give them something. So antibiotics are usually going to be what you jump to. But if a patient really doesn't want to be on antibiotics, you can tell them to use decongestants for their mild symptoms. So pseudoephedrine or phenylephrine are good. A lot of those can be gotten over the counter or from the pharmacist. With children, try to stay away from pseudoephedrine. And especially infants. Never give them pseudoephedrine. So decongestants are fine for mild symptoms, but I would prefer for adults with significant enough symptoms that want it, and for all children to give them amoxicillin. And amoxicillin is given because the primary culprit is Streptococcus pneumonia, and that is resistant to penicillin. So we give them amoxicillin, and that will also knock off the other major causes. Azithromycin can be used if the patient is allergic or sensitive to penicillin. Any other macrolide really can be used in place of penicillin. And these patients you're going to want to follow up on, so definitely let them know that they need to come back if the symptoms get worse or if they fail to get better over the next week or two. And the reason is because there's a lot of complications of sinusitis. The sinuses are right next to bones, they're right next to nervous structures. So we have to make sure, and they're right next to the eyes. So we have to make sure that the patients are progressing clinically. Even though these are outpatient patients usually, we have to keep an eye on their progress, and so the best way to do that is to have them call back if there's any lack of improvement or any new symptoms. So some of the more common complications of sinusitis include facial osteomyelitis, and that's an infection of the bone. That's the frontal bone right here, and this is the infection. Orbital infections are common too, both periorbital cellulitis and orbital cellulitis. This appears to be orbital cellulitis. You would know the difference between the two based on whether or not there's pain on movement of the eye. CNS infections can happen as well. Those are the most severe of the complications, and those would include meningitis, which would be obviously streptococcal meningitis, and brain or meningeal abscesses. So again, we don't want to go there. So this is why we treat acute sinusitis with antibiotics as soon as we can. All right, so acute otitis media or ear infection is an infection of the middle ear canal. So we have three sections of the ear. We have the outer ear, which is from the outer part of the ear, the external ear, to the tympanic membrane. We have the middle ear, which is infected here. That's the tympanic membrane to the eustachian tube. And then the inner ear, which is the eustachian tube all the way to the nervous structures. So this is an infection of the middle ear canal. The symptoms are most prominently and not surprisingly ear pain, and some patients may experience a decreased sense of hearing, but 90 to 100% of these patients are going to have ear pain as their presenting symptom. So for formal diagnosis, you would have to insufflate the tympanic membrane to check for immobility, which in AOM, in acute otitis media, in an ear infection, the tympanic membrane should be immobile. Now, are you going to do insufflation of the tympanic membrane for diagnosis? Probably not, because this is an obvious diagnosis. But you should know that for formal diagnosis, you have to do insufflation of the tympanic membrane. But we don't always treat on formal diagnosis. And even on the USMLE, you might not be asked to treat on formal diagnosis. They may give you a patient with otitis media, and they may ask, which of the following is the most appropriate step in management of this patient, and it'll give you a list of medications. So the diagnosis is primarily made clinically. Culture plays little to no role in acute otitis media. That would be primarily done for the very refractory causes, again, and that would require tympanocentesis. The treatment here, because it's most commonly caused by strep pneumonia or those other causes, Moraxella catarrhalis or Haemophilus influenza, we're going to just give them amoxicillin, and we have to give amoxicillin, again, because strep pneumo is resistant to penicillin. If they are allergic to amoxicillin or penicillin, or they request a different drug, then you can go ahead and give them a macrolide. Most commonly we use azithromycin, but again, you can give them any macrolide in exchange for a penicillin. Okay, so this is a normal tympanic membrane, and the way I would describe this would be pearly. So you got this nice kind of whitish pink structure here. This is your membrane, and then you can see here the structures of the inner ear. You have a little bit of vessel here, but I mean, you got some capillary, of course, but this is primarily whitish pink. Again, here, primarily whitish pink. You've got a little bit different lighting here, but again, you can see that nice pearly, shiny structure of the tympanic membrane. That's good. And you can clearly see the bones inside. Okay, no bones, can't see the bones here, and look, this looks bad. This is friable tissue, it's infected tissue. Here you have acute otitis media. Now, what's important here is that this is going to be a tympanic membrane that's not mobile. It's an immobile tympanic membrane. The USMLE likes to throw that a lot at you. The USMLE likes to act like insufflation's done all the time. I've never seen it done. I've seen it done on video, but that's about it. So this is real friable tissue. You know, it almost kind of looks like a colon in a patient with ulcerative colitis. So this is just really nasty. And again, you can't see the structures of the inner ear. You've got a tympanic membrane here that you got a little bit of normal tissue here, but the rest of it is infected. You've got some serum in here. So this, again, is going to be acute otitis media. So, pharyngitis. Pharyngitis is an inflammation due to an infection of the pharynx. Usually it's viral, but it can be bacterial. So pharyngitis is most commonly referred to as a sore throat, and oftentimes patients will report fever. So pharyngitis or sore throat, also I'll say sore throat here, can be caused from two different things. Pharyngitis can cause a sore throat, and an upper respiratory tract infection can cause a sore throat. So it's important to distinguish an upper respiratory tract infection from pharyngitis, in that pharyngitis will never have a cough, whereas an upper respiratory tract infection always has a significant cough. So if a patient comes in and they say they have a sore throat, one of your questions should be, do you have a cough? If they say, yes, I do have a cough, pharyngitis should be pretty much crossed off your list. But if they say, no, I don't have a cough, then pharyngitis becomes more likely. A couple other physical exam findings that are going to be important, particularly in the bacterial pharyngitis and the streptococcal pharyngitis, is cervical lymphadenopathy, which is obviously palpable cervical lymph nodes, large cervical lymph nodes, and they should be painful. And pharyngeal exudate, which I'll show you some nice scrumptious pictures of. And those are going to be keys to diagnosis. So you should always be feeling your patient's neck and looking inside their mouths. For diagnosis, we use the rapid streptococcal antigen assay and strep culture. We get both. And so here's why both are important. For adults, with rapid streptococcal antigen assay, you can pretty much go off of that. If they're positive, you treat them for streptococcal pharyngitis, and you're going to give them penicillin. If they're negative, you can pretty much rule it out. But you're going to still have the strep culture and check the results on that and document it. For children, it's a little bit less straightforward. Children have a higher false negative rate with the streptococcal antigen assay. So a child that has a positive streptococcal antigen assay, definitely treat them. If they have a negative streptococcal antigen assay, you're still going to want to follow up on that strep culture because they could be a false negative. So with children, much more than adults, following up on that strep culture, even if they have a negative assay, is going to be very, very, very important. So like I said, if it's negative assay, negative culture, if it's viral, it's just supportive therapy, fluids, etc. If it's bacterial, penicillin or macrolide. Why do we use penicillin here? You could use amoxicillin, but penicillin is perfectly fine here because this is Streptococcus pyogenes, and Streptococcus pyogenes is susceptible to penicillin. Of course, if you have a penicillin sensitive or allergic patient, go ahead and use a macrolide, azithromycin, or erythromycin, or whatever. Doesn't matter. I would say in the USMLE, though, azithromycin is probably going to be the most common one that they give you as an answer choice. Okay, a little bit of review here. So here you have your tonsils here. They look a little pink. I don't know if they colored that in to distinguish them, but here's your tonsils and your adenoids. So tonsils and adenoids are both lymphocytic tissue. Between your tonsils and adenoids, you have these arches that kind of go between the two, and they're called tonsillar arches. So you have tonsillar arch here and tonsillar arches here. And this is the soft palate here, and then this little snaky thing that hangs down is the uvula, and that's going to be really important when we think about abscesses of the tonsils, which we're not going to talk about here, but as a surgical topic, as a complication of untreated or insufficiently treated streptococcal pharyngitis, it is going to be important. Okay, so this looks red, but this is, I assure you, normal. So here you have tonsils here, uvula. You've got your arches here. So this is a totally normal patient. Okay, ew. This is gross. Look at this. White crap all over their tonsils. So tonsils are infected. You got, and this is just superficial infection. It's not going to require the tonsils to be taken out by any means, but you've got infection of the tissue on the tonsils, and I bet if you looked even back further into the pharynx, you'd see more of this stuff. So this is exudate. And I would find this particularly disturbing because where's the uvula? Oh, it's back here. You have uvula deviation, and that is a sign of an abscess. And so this is significant. But this patient certainly, for our purposes, does have exudate. And so this patient, without a doubt, is going to be going on antibiotics, penicillin. Ooh, more bad. So here you've got, I don't even know, this is a weird picture. Here's the tonsils here. I don't even see the uvula. Is that it? Maybe right there. So again, more more exudate. Okay, here's another one. So you can get the picture. How about this patient? What's wrong with this patient? This patient has pharyngitis too. This patient has viral pharyngitis. So no tonsils. They got some tonsillar arches here, but they got no tonsils. But this patient has viral pharyngitis, so no exudate. Okay, so we've got to treat bacterial pharyngitis. So when I'm saying pharyngitis here, I mean streptococcal pharyngitis. Why? Subcutaneous nodules, Coca-Cola colored urine, erythema migrans, starting to sound familiar, mitral stenosis. Rheumatic fever is a big problem in patients who are untreated who have streptococcal pharyngitis. So we don't give antibiotics to make the patient's pharyngitis go away by the strictest sense of the word. When we're giving antibiotics, it's not going to change the duration of the illness. We give antibiotics to prevent rheumatic fever from happening, to prevent all of this stuff from occurring down the road. So that's really why we're treating the pharyngitis. This is our primary concern. We don't want this to develop because mitral stenosis and post-streptococcal glomerulonephritis are bad. And post-streptococcal glomerulonephritis can develop within weeks and months of the strep infection. Generally, the mitral stenosis takes a lot longer. This is the Coca-Cola colored urine or the tea-colored urine. This isn't specifically from a patient with post-streptococcal glomerulonephritis, although it would look just like this. This happens to be from a patient with rhabdomyolysis, but they both look the same. So, all right, influenza. So influenza, up until now, we've been talking about localized illnesses. Influenza is a systemic illness. And you're going to notice that this is a systemic illness based on some of the symptoms. And this is caused from from an influenza virus strain. There's multiple different strains. And so because of that, everybody should get the influenza vaccination every single year. Now, of course, there are people who don't get it because they're paranoid about it. But there are people who don't get it because they really shouldn't get it. And those people include women who are pregnant in their first trimester and people who have an allergy to egg products. The symptoms for influenza are going to be a lot of the symptoms that you see in some of the other ear, nose, and throat infections. So runny nose, cough, sore throat, headache, fever, maybe some fatigue thrown in there. But what really sets this apart is the malaise, the injected red eyes, the myalgias. Now, these myalgias are so important. You know, when you have, when you don't want to, you know, you're just sick and you don't want to move anywhere, and every time you sit down or you just got that kind of, that's myalgias. We're not talking about fibromyalgia here. We're talking about just pain everywhere. You don't want people to touch you. That's what influenza causes. And really what that is it's caused from just a highly elevated amount of inflammatory mediators running around in your bloodstream, and it's reducing your pain threshold. So myalgia is a common link to influenza, but really these constellation of symptoms are associated with influenza. So it's everybody kind of shows influenza in different ways. I mean, it's not like in the other disorders where you've got a perfect constellation of symptoms that you can rely on, but these general myalgias and malaise, and particularly the conjunctival injection, those are some things that are more associated with influenza than not. These patients are really going to look sick, and that's really because they are sick and they feel like crap. The diagnosis is going to be the rapid antigen detection, and that's done very quickly and in the clinic, and that will easily rule in or rule out influenza. Now, very important that you know when the patient's symptoms came on. If it's Thursday and the patient's symptoms came on Monday, that was 3 days ago, so we're just going to give them supportive therapy. And that's going to be fluids like an antibody, adequate nutrition, rest, NSAIDs for pain. If, however, it's a Tuesday and the symptoms came on last night, Monday night, if it's any time within the last 48 hours, then you can give them oseltamivir or zanamivir, and these are antivirals, and these are given actually to shorten the duration of the illness. So it's not like the antibiotics we give for strep throat. This is actually to shorten the duration of the illness. So oseltamivir or zanamivir.